Arkansas Medicaid has a pay-for-performance program for hospitals where we are pushing people to get a B+, A-. And I can tell you that we go in front of the public, we talk nationally, we talk to Medicare and others. They say, well, what about quality? You know, you're talking about dollars, where's the quality? And so what we're putting in place here are must-pass and to-track data. And but this is not a pay-for-performance program. This is a effectiveness program. And so what we're putting in place here is if we're going to gain share for reducing costs, we're expecting people to at least get a B- on the quality metrics. So we're not, and it's things like, you know, did 75-80% of your patients get HIV testing before they got delivered their kid? I mean, these are basic core measures of care that we think are really core to the delivery of care. We're not expecting perfection. We're not trying to weed you out, but we're trying to say to the public, okay, we're going to reward people, but we're not short-shrifting the system, that you're going to be getting a quality product, and we're expecting a certain level of performance in order to gain share. Now, the other piece is going to be that some of these metrics, we try to do as much of it as we can with administrative data. Some of it we can't capture. And so some of this, on a couple of it, depending on the topic, we are requesting some, we have a portal now to enter data in. We don't want to have burden on the providers. We're trying to keep that as unburdensome as possible. If you don't want to put in that data, that's fine, but then you wouldn't necessarily be, you wouldn't be eligible for gain sharing. So if you want to be in gain sharing, we're trying to ask for some data submission. But it's, you know, again, we're calling this version 1.0 because in many ways we're trying to do something that hasn't been done. And as time goes along, the capacity for electronic charting to extract that data will become better. So again, this is a formative process. Yes, sir.
Does this take into account patient baseline characteristics? Like, you know, yes. Again, for some patients are sicker than others, and so does this take into account?
We are working with, you know, experts in the field, local providers. We're developing risk adjustment methodologies where we are dealing with exclusions. So yes. So for example, we were looking at something with cholecystectomy about inpatient, but we realized a lot of people are coming in with pancreatitis. That's a different animal than an elective or an acute cholecystitis. So we're excluding people who present with pancreatitis. So things like that, sure. Absolutely. We do want this to be fair. Now, on the other hand, are we going to make it completely foolproof? The answer is no. But on the other hand, if you go back to that slide, it's on the average episode, and everyone's going to have one or two, you know, things that don't quite, you know, aren't quite, if you will, straightforward cases. But over the long run, it should even out. So we're going to try to play that as well. Again, if somebody gets disadvantaged, we can work through that later on after the fact. Go to the next slide also. We're also giving people a chance to react to how they're doing. So what we're doing now is we give people report cards. So when we started the episode in July, everybody got their report cards in August, but we didn't start, if you will, start the clock where people were accountable for the care they were delivering until October. So everybody on the first wave of episodes got a report card, showed them where their costs were, and it's about a 5 or 6 page report card, shows them the cases they did and their relative costs, where they were, whether they were in a gain sharing or the risk mode, how they did on their quality metrics. Look at the next slide, please. We also gave them their number of cases and what their performance was relative to their peers and what their expected costs were compared to their peers. So you can look at the framework and you can see, well, gee, my patients had more outpatient lab than my peers for the relative numbers. On the other hand, my other category, well, that's not a good one, but well, you can go over here, but my pharmacy costs and my ER use might have been lower than my peers. You can get a sense of where the episode costs you were accountable for, where the dollars went. And so we've actually had discussions with a couple of OBGYNs who are outliers One person had higher inpatient charges than his peers. Another one had more outpatient surgery charges, and we were able to dissect down why they were an outlier to give them a clue as to how they can make adjustments in their practice style. Next slide. These were the initial episodes: total hip and knee, perinatal, colds, heart failure, that's the hospital, and ADHD. So we're doing episodes in different categories. Again, some of that's different payers. And we have different different PAPs, orthopedic surgeons, primary care docs, hospitals, psychiatrists, psychologists. The current new episode wave we're doing is colonoscopy, cholecystectomy, tonsillectomies, and oppositional defiant disorder. We're also working on long-term care, and we're working on primary care, medical home, and total cost of care as well, but that's going to be for later in the year. Next slide. For colonoscopy, we're talking about having input. We're working with the groups, having something help potentially up and running in April, and getting you report cards in the late spring, getting feedback and giving feedback in the summer, and starting the episode in the fall. So starting around Labor Day or thereabouts, having the beginnings where things would count, and everybody would be you get the report card in the summer to tell you where you are, and during the period of performance assessment, you'd still get quarterly report cards, so as the year is progressing, you know where you are, and you can get a sense of what your practice style is doing and what your caseload is doing. The big picture on the colonoscopy episode is before you. Colonoscopies are diagnostic or screening. Most of the colonoscopies these days are probably screening. They present often to a PCP who either sometimes does a pre-procedure workup or sends them straight to the gastroenterologist or surgeon or whomever does the colonoscopy. Likewise, sometimes people present to the emergency room with some sort of acute event, and those are being excluded from this. Very often that's an acute bleed or some sort of unstable situation, and really is a kind of a very different episode of care. We do have some patients that will present with chronic diarrhea, that kind of thing that needs an assessment. And so then they go straight to the GI for a different kind of a workup. The question then comes down to is the place where the procedure is performed. Can be done as an outpatient area, an inpatient area, can be done with or without an anesthesiologist. The patients can be sent home the same day. They sometimes can be admitted for overnight observation. Again, a variety of things can happen. Some of that's practice style, some of that is skill, some of that is patient mix and pre-existing conditions on the patient. Go to the next slide. So, where are the sources of value? Again, reduction in complications, effective use and strategies of sedation, choice of which procedures are being done, and again, issues, a reduction in need for repeat procedures, that kind of thing. So if all the care is done in one event or multiple events, it can change the cost and the outcomes of the episode. So let me, at this point, turn the proceedings over to Dan Tsai of McKinsey, who can go over the episode construction and some of the data regarding colonoscopy in the state.
Thanks, Dr. Golden. So page 18, you'll see on the left-hand side, again, this is just for two of the pairs, Medicaid, Blue Cross Blue Shield, left-hand side, just over 1,200 colonoscopies over the course of a year. 775 of those were colonoscopy with an additional procedure, polypectomy, et cetera, that sort of thing. And 470 of those or so had no additional procedures. And Medicaid had 160 different performing providers. These are the physicians that were actually performing the colonoscopy. On the right-hand side, you'll see that same data for Blue Cross Blue Shield, 8,500, a little over that in the number of colonoscopies. And here for Blue Cross, it's broken out between diagnostic colonoscopies and screening colonoscopies. So the majority of them are diagnostic colonoscopies, 5,800 or so. And you have about 1,100 screening colonoscopies that had an additional procedure, and 1,500 screening colonoscopies with no additional procedures. And the total number of performing providers for Blue Cross Blue Shield was 285 over this 12-month period. So before I get into the episode design for your feedback and input, any questions so far on the material covered?
These numbers seem flip-flopped or skewed, but also, is this indicating that every diagnostic colonoscopy did include an additional procedure? Even if it was, like, I would assume a biopsy or a polypectomy would be included as an additional procedure, but not a single diagnostic colonoscopy didn't include an additional procedure.
Great.
And that's one of the key aspects of the way these episodes are going to be designed, and that was brought up as far as we try to capture as much as we can from the administrative claims data. The way Blue Cross's claims currently are being captured, it needs to have a diagnosis or a procedure that indicates that it started as a screening colonoscopy, or if it does have the CPT code indicating additional procedures, there's a modifier that says that it was a conversion from screening. If the coding is inconsistent, then we aren't able to identify that it may have been initiated as a screening. So it is very possible that a good portion of these diagnostics with additional procedures may have originated as screening colonoscopies, but there was no indication in the claim to let us know. There were very few rare cases of a diagnostic-only colonoscopy, but most colonoscopies that are not likely to result in additional procedures are just screening, and so those seem to be coded properly. There were, I think, fewer than 10 after we ran some exclusion criteria for really unusual cases in the state. Since they were so unusual and so rare, we didn't want to include them in these numbers because it's one of those factors that if it's not the same and it doesn't happen very often, then we don't want to cloud the overall picture of what's happening.
I would add currently Medicaid reimburses for diagnostic colonoscopies at this current time. I don't know if you have anything to add on that, Bill.
No, I mean, as I said, payers are changing, and I think that the historic approach on Medicaid was there had to be a diagnostic reason for doing the procedure. Now, people found reasons to do them, but with the potential for Medicaid expansion, it's very likely we'll be changing our coverage and make it consistent with other payers.